Hello, everyone. May take a minute to load here. Rebecca again. Hello. Let's see. Go gallery view. It's easier to see you all. All right.
Dr. King, I'm going to say just first up, I may have to leave.
That's okay.
Partway through the class, we're dealing with some issues with my son who you saw come in the last class.
Yeah, no problem. These classes are totally optional. And honestly, there's so much material covered in the diagnosis class that we're going to talk generally, but I mean, not super specifically about, because there's no way for me to cover all the different diagnoses in like an hour and a half so that we cover it. So yeah, no worries.
Okay, I wanted to let you know up front that we've got stuff going on and I just may have to.
No problem. Okay. All right, and some people here that I don't know, and some of you from the previous class, so good to see you back. Let's see. Hi, Heather. Lisa, hi. I don't think I've met you yet. You're brand new.
Can you hear me?
I can, yeah.
Okay, yeah. This is my first class with y'all.
Okay.
I'm already a school counselor. I'm just getting a few extra hours to try to take the LPC exam.
Awesome. Well, welcome.
Thank you.
Hey, Carlos.
Hello.
Hi, Carlos.
Hi, Rebecca. Glad you're back again.
Happy to be back.
And same with you, Sonia. Long time no see. Just kidding. They were just in my ethics class earlier. So, hi, Eric. Nice to meet you.
What's up? How you doing? Good to meet you.
Glad to have you in the program. I love seeing all the new faces.
Yeah.
I guess I'll meet everyone in the orientation, but
yeah. Thank you.
And then Denise. I'm not sure I know you.
Nope, this is my first time taking you.
Okay. Do you mind if you do the video or?
I don't know what it's doing. I don't know why it's my first time using Zoom. So
I'm going to request for you to start it.
There you go.
Perfect.
Oh, and I'm at home mode, so forgive me.
That's okay. I'll tell a story. The other day, so for those of you who don't know, I live in Dallas, and I had a meeting with some colleagues the other day, and I knew they were Zooming me in, but I didn't realize I was on like the big screen TV in the conference room. So I'm at home, working from home. I'm like in a t-shirt. I mean, I look, but had I known I was on the big screen, I probably would have tried a little bit harder for that meeting. So no judgment here.
Yeah, I'm in home mode and my hair all up, and yeah.
Awesome. And then Jimmy, hi, you're new as well.
Can you hear me?
I can.
I'm trying to fix my camera. I just got a new computer.
No worries.
Okay, I'm working on it.
Okay, no worries.
Okay.
And then some of you have had before. Hi, Krista. And Brandis. Okay, cool.
How are you?
So this class is going to be super loose, like even more loose than the ethics class. So I'm just going to kind of, because there's so much that we cover every week, all the different disorders, I pretty much stick to the video lectures there. This is really for kind of just review and questions and like concerns that you have about the class that may come up. So that's kind of what's going on here. But that being said, today we're going to kind of just talk about general, like why we diagnose and orienting ourselves to the class a little bit. And then a little bit about how culture can come into play with diagnosis as well. So first of all, does anyone have any questions about the class? because I know some of you have been emailing me, which is awesome. I'm totally open to that. I just wanted to know if there's anyone that I've missed that maybe.
Well, there was supposed to be a discussion this week, but there was nothing, or last week, but it was never posted.
Yeah, so let me tell you about that. I'm sorry about that. So I revamped, well, all of us in the whole program have revamped all of our syllabi for our K-CREP site visit. So really that discussion is happening in class today. So I apologize for the confusion there, because I know that in some of my other classes we have online discussions. We don't do that as much in this class. Really, the structure of this class is, it's more about, it's really content oriented as opposed to like, let's flesh out this issue through discussion. So we just have the one assignment that you guys already turned in, and then we have the treatment plan assignment that you turn in a little bit later, I think October 6th or something. And then you have 4 quizzes over the material that you're covering each week, and then you have the midterm and the final. So those are timed quizzes. Every week I'll have videos up for the various disorders and kind of what's covered in the chapter. So I highly recommend reviewing those. And then you can read the PowerPoints as well. I know we have different types of learners. I'm a really verbal learner, so I like to listen, but some people, may just want to read. And so that's up to you. Does anyone have any other questions about that?
Well, is the quiz and the midterms, are they essay, or are they multiple choice, or are they, how is it structured?
They are multiple choice for the most part. There may be 1 or 2 questions where I ask, like, give an example of something, but they won't be essay. Now that I'm like, oh great, I probably have an essay in there. I need to go back and look. I will go back and look and check for sure. From what I recall, they're pretty much all multiple choice, or maybe some short answer.
So, obviously part of grad work is gathering the information you really need and being able to sort through all of that. And I'm a very visual, verbal learner, and I'll read all 100 pages if I need to, but are your PowerPoints more the areas that you really need to focus on in those?
No, I have all the criteria in there.
Okay.
But I will say that, my quizzes are mainly, what is this diagnosis? What does it mean? You're going to want to look at like duration of time to determine like how long has this been happening, the symptoms, and just the like general definitions of the actual disorders are kind of, so let me just kind of explain my goal for you in this class, because it is so much information. It's really content heavy. And y'all are like, yes, it's been scary already. I know.
Well, like for example, like when we were reading about the DSM and the specifiers and the non-specifiers, like I know that we have to know what that is, because if you get into clinical diagnosis, then you have to be able to code those for billing and all that stuff. But like right now, is there a need
Like,
to?
I will never ask you to memorize an ICD code.
Okay.
I will
So,
never ask that. Like,
just a general knowledge of what that is.
yes. So basically, like that first assignment was just to orient you to the book somewhat, to let you know like why we diagnose. We diagnose for a variety of reasons. Actually, why don't you guys throw that out? Why do we diagnose?
Treatment plan, so that we'll know how to treat the patient or the client.
Yeah.
Being able to do evidence-based care, research-based care for clients.
Absolutely. Yeah, it guides you in the direction you need to go. What else?
Money.
I know. Yeah. That's the big one. Insurance.
Insurance billing.
billing. They will pay for things, they'll pay for treatment if you have a diagnosis.
Yeah. Well, and I come from a medical billing background. I took medical billing and coding prior to even doing anything that I do now, and just having to be so specific to get insurance companies or Medicare to pay is difficult, and you have to have an accurate diagnosis.
Absolutely. Yeah,
Treatment plan.
You definitely need an accurate diagnosis and a treatment plan. And, I think you all are right on when you talk about how having that accurate diagnosis can really lead you to a wealth of information, research on these various disorders. And it's also really good for clients. Well, it can be, and it can be stigmatizing as well. So let's talk a little bit about that. What are the positives for clients when they find out their diagnosis, you think?
Well, when you have an idea of, okay, now we know what's wrong, we can start fixing it, or.
Yeah, absolutely. Name it to tame it.
It also, because there is a diagnosis, it means that it is a real thing, that it's not all in their head, so to speak.
Right.
So that this is something that's diagnosable and treatable, and there's help instead of just I gotta suffer the rest of my life.
Yeah, it provides them with relief. Like, oh, there's a thing in this book that a bunch of really smart people have decided is a true thing that I have, and it gives people hope. You're right. Anything else on the positive side?
Well, it can give them resources. Not so much from a mental health standpoint, but I know with, my, autoimmune disorder, having a diagnosis gave me a place to start for support groups, for, things like that. And I would imagine that a lot of mental health is similar.
Absolutely. You can seek out all the education around that once you know what it is. And you can find those supporters that maybe are experiencing the same thing. So awesome. And what are some maybe drawbacks to diagnosis?
Having a label.
Yeah, the stigma.
Stigma, for sure.
Well, and it can also be limiting. I mean, if you stick somebody in one diagnosis, that might not be the entire picture.
Absolutely. Yeah, they might have multiple diagnoses, or if they're diagnosed incorrectly, that can be problematic too.
Well, that's just like Kevin Hines. I don't know if anyone knows who he is, but he's a survivor from the suicide. He was, because I teach mental health first aid, and we show 3 of his videos. Really? Awesome. On the youth one, we show 3 different videos from him. And, he said, he didn't want a bipolar. I'm not that.
Wait. Can you pause? Because some people in here might not know. So do you want to tell everyone who Kevin Hines is?
Yeah. Kevin Hines is one of the few survivors of a suicide attempt off the Golden Gate Bridge. Golden Gate Bridge has a 98% success rate for anyone that attempts suicide. 95% die on impact, and then the other 3% usually drown. So he is kind of an amazing man. And so he had schizophrenia. He had lots of voices telling him, you must die. And unfortunately, he Googled something. He doesn't say what he Googled, but one word. And there was a website that said, whoever you are, if you're in San Francisco, go Golden Gate Bridge, jump off, good luck, ! So he did. And so he is now a motivational speaker. You can find videos of him on Facebook. He's an amazing, amazing man. I would strongly encourage you to look him up and see some of his videos, because it's very inspiring. There's also a documentary called The Bridge about Golden Gate Bridge, and you can, it can be very sensitive to watch it because you see suicides on it because they had a stationary camera, but he does an interview in it too. So he's an amazing man. So please look him up. But anyways, he talks about how, they diagnosed him with bipolar, and goes, I'm not bipolar. I don't know what this is. I don't want to be bipolar. So it was a barrier for him because he didn't want to admit to what they told him he had. So that was kind of a negative to the diagnosis initially, until he finally accepted.
Yeah, it can be really hard for people to feel like they might have a diagnosis because of stigma, like we've said, that in their communities, maybe they've been taught that makes them crazy or not right or not okay. When in reality, some people have heart problems, some people have diabetes, some people have, I don't know, a variety of health diagnoses, and we don't look at those as character flaws or defects or caused by the person or, those sorts of things. So there's still a lot of stigma, unfortunately, around mental illness and struggles with mental health. So that can be a drawback for people, for sure. So my goal for you in this class is just to get enough of a handle on the DSM that you know how to use it, how to find what you're looking for, and an awareness of enough familiarity with the diagnoses that you can go, this really seems like it's a bipolar related disorder. And then you look at your DSM and you look at the symptoms and you really know how to break it down and find the correct diagnosis. So I hope you bought your book. If not, the DSM-5 is something you should just get, because it's something you'll need.
It's our Bible.
One of them.
Totally.
Along with the ethics code and the laws, and it's okay, it's one of them. So I definitely highly recommend just having it, even if you're a school counselor, because you aren't going to be diagnosing in schools, but it's really good to have that awareness. Why do you think that might be important, to have an idea of what the diagnosis is as a school counselor?
So you can give resources to the family.
Mm-hmm. Yeah, and get them to the right referrals. It could even inform their 504s or their IEPs. So excellent point. The more knowledge we have, the better we can help the people that we're serving, even if we aren't actually doing diagnoses in a school. Even if you're an LPC, so in your outside practice, you'll be able to diagnose, but in a school, you wouldn't do that in your role. However, it doesn't mean you don't have that knowledge. By the time you leave this class, I just want you to be able to have enough familiarity that you know the right place to look, and you have an idea, a ballpark range of how to figure out how to diagnose your clients. You probably won't be actually diagnosing for a while, because even after you graduate, you'll have a supervisor, and then your supervisor will be the one that's able to diagnose. But you will probably be creating treatment plans, even maybe starting an internship. So that's the purpose of the class. Hi, Jimmy. We can see you. Nice to meet you. Still can't hear you, but that's okay. We'll work on it.
Okay, there. How's that?
Okay, cool.
Okay.
Bye,
everybody.
Okay, so that's kind of what I'm going for in this class. So like I said, my quizzes and my tests are really geared toward you understanding the various diagnoses. It keeps it simple that way. Let's see. How does culture impact diagnosis, you think?
Well, depending on a culture, what we would consider, a disorder might not be for another culture. Especially if you get into some of the like shamanistic cultures and stuff like that, what we would consider hallucinations and delusions, and that might be in their culture, they're touched by God, kind of thing. And you have to kind of consider that, because that's not going to, it will affect how you will treat it, how the treatment is received, but it also is, a disorder only comes if they can't function, in different settings. So if they're functioning within their cultural settings, then it's not really a disorder.
Right. That's a great point. When I think about, what is a what constitutes a diagnosis, you have to be impaired. You have to be unable to function in some way in your life, whether that's in your relationships, your job, or other areas of functioning in your life. If it's not causing a problem, it's not a diagnosis, right?
Mm-hmm.
And a prime example of that when I think about it, is like gender dysphoria. Just because someone's transgender does not mean they have gender dysphoria. Because if someone's comfortable, let's say they've already gone through the process of transitioning and they're comfortable in their community and their relationships and in their body and they're just happy, then that's not a diagnosis, you know? But I think, culture plays a huge role. So thank you for pointing that out, that in some cultures, they might be seen as wise or spiritual or tapped into something else that is revered in their culture, right?
I think too that culture really could hinder someone from coming forward and receiving treatment or even going to the doctor to get help.
Yes. Can you tell me more about that?
I mean, I just think in some cultures, it's just frowned upon. Families don't understand that that's a real problem, that mental health is actually a real problem. And I think it's frowned upon by their families. And so then we have to really try and educate families in addition to the patient to help them.
Absolutely.
Family members.
Hispanic cultural is very resistant to mental health. The Hispanic culture, you know, you're just supposed to get up and do what you need to do, and you know, that's just an excuse. You know, it's not a real thing.
Well, I think that could be common in a variety of cultures, you know,
or even just men in general.
There's so many different cultural aspects that come into play, right? Male.
Well, you also have the, career culture. I mean, I was a military wife, and my ex-husband, developed severe PTSD from multiple deployments. But he was really discouraged, by his superiors from seeking mental health help while he was still enlisted. That was like considered a mark on his record. He wasn't combat ready. He wasn't, so I mean, it was something that they were actively discouraging, for quite a while. And it's just been very recently that they're, pushing more of mental health care within the military.
Right. Yeah. So a culture can definitely deeply impact. And I mean, thank you for sharing that story, because I definitely think the military is like a very specific subculture that has a lot of different interesting and important issues around mental health. And when I was a school counselor in Vietnam, it was a very different approach to, there really wasn't a lot of education around mental health or mental illness. And so, like Lisa was saying, we did a lot of educating. And I don't know why that is. It's just not infused in the culture. And there's not even a huge field, like psychology field over there. So I was in a really large city, so there were psychologists and there were resources and things that could help kids, but we had to spend a lot of times, parents really didn't understand that their child was, maybe severely autistic. They just thought they were acting out. So, there can be like a minimization or a denial in certain cultures. But that's not to say that, that was a very specific culture that was in Vietnam, and I'm sure it was very different in the rural Vietnam. I was in a huge city. So, I mean, I just think there are so many compounding factors in which culture can play a role. Also, I'm thinking of like individualistic cultures versus collectivist cultures and how that might impact diagnosis, that can play a role. Yeah. Any other thoughts on that? Okay. Go ahead.
When you're saying individualist cultures versus collective cultures, are you talking more like, like typical US is considered more individualistic, whereas, you might go to, let's say, China or Japan, and you have multiple generations like living together. Is that what you mean by individual versus collective?
Yeah, or even like, I know Latino culture is very family oriented. And maybe more collectivist. All of this is on a continuum, but yeah, that's what I'm thinking of. And that could impact. And maybe there is, I'll just speak again from kind of my experience in Vietnam, which was extremely collectivist. There was a real cultural shame in losing face or discussing problems publicly. The idea was that everything should be handled in the family, right? So that could keep people from getting treatment, or even the way that you look at treatment. So like child protection issues, even the way that child protection or abuse issues were handled was collectivist, which is really interesting when you think if it's happening in the family, how do you address that, right? So a social worker would come in and kind of work from the inside, but it's complicated, but they couldn't even really call the police. They had to call someone in the community, and then the community warden kind of like came in and helped. And then like they tried to kind of convince the family to either reject the person who was abusing or stop, work to stop the abuse, but it was like a very sensitive, involved way of, even the laws were shaped by this collectivist structure. So anyway, that's kind of a tangent, but yeah, I think that can impact diagnosis, and what's considered extreme behavior in one culture is not considered extreme in another,
I know even in China, they don't recognize mental health as an issue at all, and the families are shamed if a child suffers from any type of anxiety disorder, anything like that. They are not allowed to bring that forth, or they're rejected from their families. And so you have to be careful with those parents how you handle that, and make sure you're coming at it from their perspective, or they reject you immediately.
Absolutely. Yeah, I feel you on that. It's really about trying to understand their culture first, and then trying to find a way to connect the dots so that the child gets the help and the family doesn't feel shamed, and all of those different things, which can be really challenging and complicated. Another thing, and thank you for sharing that. So another thing I'm thinking about is gender. How might gender play a role in diagnosis?
Well, that's what I was saying a while ago, is men, it's going to be harder for them to get help because they're supposed to be men, they're supposed to just tough it up and just deal with it. And so it makes it harder to probably diagnose them, because they're not going to be as forthcoming with certain things that they may feel is a weakness. So
yeah, so there's some, and like you were saying, Brandis, with the military culture, like maybe that's seen as a sign of weakness to admit that you might be struggling with mental illness, let alone seek out help, right? But we know from MHFA that those suicide rates are a lot higher in the male population than the female population, right?
Well, females attempt more and men complete more. So,
and so there's that discrepancy there. And there are certain diagnoses that are skewed by gender. So there are biases that we've worked to eradicate in the DSM. However, our culture has changed over time, right? So the DSM has evolved with the culture, but homosexuality was considered a mental illness a couple of versions of the DSM ago, right? So we know and accept that that is definitely not a mental illness. It's a sexual orientation, and there's nothing wrong with it. And, you know, we are affirming and accepting of that in the profession. However, previous versions did have that as a mental illness in the past. So it kind of makes you wonder, as our culture continues to shift, what might become outdated in the future, you know?
Don't you think some disorders that are hereditary are more prevalent in different genders? So just females may be more likely, you know, to
Well,
inherit.
and we do see the prevalence rates broken down by gender in the DSM, so you can kind of see that. But it's kind of like everything, right? Yes, there are certain hereditary characteristics that get passed on, but maybe in varying degrees, and also environment and culture and maybe what the person goes through can also impact the wiring in the brain as well. I hope that answered your question. I'm sorry.
Yeah, no, that did.
But I am thinking of one diagnosis in particular, borderline personality disorder. So have you guys heard of borderline personality disorder?
Mm-hmm.
I have some clients that have it. It's fun.
Yeah, I bet they're all women, aren't they? Every single one of them, right? Yes. So borderline personality disorder is one of those disorders that's very controversial in the field, because men are like almost not even considered. Like, you won't even see that diagnosis on a man, even if they are borderline. They might get a different diagnosis, but it's very rare to see a man with borderline personality disorder. So is that cultural, or is that women just naturally tend to have those traits more?
But aren't men more diagnosed with antisocial personality disorder than women, though?
They are.
So it's kind of the flip side of that.
That's right. And so we do have those. And I think, you know, maybe that has to do with some of our chemical makeup, like increased testosterone for men might make them more aggressive, which might lead them to more antisocial behaviors. However, there's a bias that gets ingrained as clinicians when we're doing this work, because we see it more frequently, right? So I think it's hard to take off our biases or our perceptions to see, oh, well, maybe this guy has borderline personality disorder, or maybe this woman is truly antisocial. Maybe because, you know, it'd be easy to say, oh, well, maybe that person's traumatized, and so they're like using defenses. I mean, there's so many different things. Does that kind of make sense? So it's just an interesting thing to kind of be aware of as you're going through and you're learning about these different disorders, to look at the prevalence rates broken down by gender and by culture, and kind of use your critical thinking skills to think through how that might play out in your own practice.
You know, when you're talking about, you know, gender and prevalence rates and things like that, you're talking like just, I don't even want to say necessarily strictly biology, because even with biology, there's like 18 genders, I think, if you go strictly by genetics, because you have like male presenting, you know, female, you know, and I read an article on it. It's hugely confusing, but what about, you know, like those that are, you know, gender fluid or the trans, or, I mean, where do they fall into that?
I think that's a really good question, because if we can learn, I mean, I think that there's a lot of like physiological questions that we've yet to answer about the brain and gender, and if there's a connection there or not, you know, because that could impact, I think, diagnosis as well, or how someone presents in a wide variety of ways. I think you make a good point there. Yeah. But yeah, some of the other like diagnoses, and that's why, yeah, I just want to encourage kind of critical thinking as we're going along, because what is the most highly diagnosed mental health concern with children, you think?
ADHD?
ADHD is what I'm thinking.
Got it. ADHD. So is that cultural? Are we just not serving children in the way that maybe they naturally need to be served in schools, because maybe they're not meant to just sit for 8 hours a day? Or
from a teacher standpoint, I honestly think that some of our kids that have been labeled as ADHD, now not all of them, but I think some of them, are being labeled as such because we've removed things like physical education. They don't have recess anymore. They don't, with all the testing that we're doing, we're not even allowed to, like, as classroom teachers, to really, get up and get into those moving and involving, projects and things like that. It's as much anymore, so I think some of it just is developmental. I mean, kids aren't meant to be sitting still for 2/3 of their day.
Mm-hmm. Well, it's just like my son had ADHD, inattentive type, and 134 IQ. Those two things do not mix well for school. They just don't. He would be bored and he wouldn't do stuff. So I had to give him on medication in school. Well, I homeschooled him for 2 years, and he did great without medication because he didn't have to have that structure. He could just do his work. I'd give him a week's worth of assignments, and he'd be done by Tuesday. I mean, just because he was smart, and if he could stand on his head in the corner and do his work, I didn't care, And so, yeah, he thrived better in that atmosphere because he didn't have that structure that school has now.
Right. So we're looking at some of these things because we always have to determine, can the person function? But maybe the environment is the problem and not the person, right?
Mm-hmm.
We're not all cookie cutters, and we can't, I mean, we have to find systems because there's a lot of people, and we have to find a way to function together and cooperatively in society. But as we, all you educators and anyone who's worked in human services knows, every person is different and their needs are different. So those are, and thank you for sharing that, Denise. That's a really great point. We also need to consider cultural influence in the sense that, so we have waves of diagnoses that become popular at different times. And why do you think that might be?
I think part of it is because when there's something new, or it may not necessarily be new, but new to consciousness of the public, then you start seeing it everywhere.
Very true.
Yeah, it's kind of like, you buy a red Camaro, and then all of a sudden you see 18 red Camaros. So, but you never notice all the red Camaros before you bought one. So, yeah, so you hear about it and you start seeing it everywhere. Even sometimes where it's not, you just happen to think you see it. So,
absolutely. I think that really rings true with autism spectrum disorder, right? That's like the new thing that is everywhere, and it's being diagnosed more and more. And there are questions about, well, is it environmental, or is the diet impacting people, or did a lot of people have autism spectrum disorder and just not know it?
And occasionally it can also be where professionals are trying to make a name for themselves, like with DID back when it was MPD still. Because they wanted to be the one that found Sybil or whatever the case may be, and so some of it was maybe forced on the person to some extent because they wanted to be the person to have that study.
Possibly, like you said, it's permeating consciousness, like the societal consciousness, and so people are recognizing it more, and then that can also lead to problems and increased stigma because someone who has brief psychotic disorder, they have multiple personalities or something like that, because people don't have a really strong understanding maybe of mental health concerns in the community. So that can be a problem too. I'm also thinking about drugs. So when a new drug comes on the market, all of a sudden, all these kids end up with the prescription. How does that happen, right? So that's one thing that can influence as well. I remember back in my day, it was like ADHD medication was a big one. And I know now, I mean, there's so many different types of antidepressants and antipsychotics and stuff. They're getting better and better, which is great. But we have to be aware of how advertising can impact as well, because if a pharmaceutical company spends millions of dollars on advertisements, well, then maybe that parent or that kid will say, oh, I have this. And sometimes it's true and it's good, but then sometimes maybe they don't, right?
Well, and you also get from the medical side, like pushing with it, because my oldest daughter is on the spectrum, but she's extremely high functioning.
Mm-hmm.
But when she was, kindergarten, first grade, we had difficulties because, like most people that are on the spectrum, she, didn't get facial cues. She didn't get emotional cues. I mean, that was stuff that we had to train her how to recognize. And in the beginning, her doctors were pushing like lots of medications on her to deal, because she wasn't a severe autistic. She was, on, I don't want to say the lower end of the spectrum, but the better functioning end of the spectrum. Mm-hmm. And I had to fight them on a few of them, because we had one combination where she was starting to have like psychotic episodes. Like she would just go into a rage and like attack other children. And the doctor is like, well, we'll adjust the dosage. And I'm like, no, we're taking her off this medication. And, and I was having to fight because he was pushing, this is what we're going to do.
Right. Yeah. Well, and that makes me think about how sometimes it's really just a collaborative effort between, because as therapists, we're never going to prescribe meds. We're not medical doctors, but at times we might have to advocate for our clients because we see them way more frequently than the psychiatrists do. And sometimes the psychiatrists, okay, they see them for 30 minutes, but they don't really get the whole picture. So we really have to collaborate with them to let them know, like, hey, this medication doesn't seem to be working, or they are telling me that they're taking like 5 times the Xanax that they're supposed to be taking, or, just different things like that. So, and yeah, medication's a whole other animal, but diagnosis is really important. If someone does need a medication, it can really help them get where they need to go, whether that's a medication route or just behavioral change and therapy, right? But every person is different. So, it's our job as clinicians to really listen to the clients, listen to the families, and try to work with them and do what's best based on their individual needs, So, but thanks for sharing that. Okay. So, I'm going to just talk extremely briefly because we will talk about this in other classes, but does everyone know that we are mandated reporters? Okay. So what that means is that anytime we find out that there's a case of abuse of a child or an elderly person or a dependent person of some sort, maybe someone with a disability, we have to report that to DCFS, Child Protective Services. And does everyone know how to do that? So there's a website, and I'll just show it to you. Sorry about my screen. It's always really junky. So most of you know, but I just want to show you. Sorry, DFPS, not DCFS. So you just go to this website, Child Protective Services, and you can push the report abuse button. You can do this anonymously, or you can do it you can do that by phone anonymously, or you can do it as a guest online. And so online, you just push Texas Abuse Hotline online, or you can call it in. So you know that we are not investigators, but if we do get a report of abuse, we are required to report it. And so that's the job of this agency, is to investigate that. And so that's kind of all you need to know for that. And we'll cover it over and over again in this program, but I just wanted to point it out. Sorry, just 1 second. And then the other thing is we are going to seek out help if someone expresses intent to harm themselves or someone else. So we'll talk a lot in the ethics class about informed consent and about limits to confidentiality. But just as a disclaimer, if someone has intentions to harm themselves or someone else, then we have to get help from the authorities and get them hospitalized. And that comes into play with various diagnoses, and some are more severe than others. And so that can be important to know kind of what the level of risk is there. But that's just all I have for you on my talking points for tonight. Are there any questions about anything we've kind of gone over, or any other comments or thoughts that you have?
I have a question. On the second online assignment, the case study.
Yes.
Because I do treatment plannings in my job, I used the style that we use, but I didn't have a reference because it's what I do. I mean, I was trained in it, so I don't know. I didn't know if that was okay. I put on the, when I submitted it, I wrote that to you because I didn't know if that was okay because we use the PCRP.
I haven't looked at it yet, but I'm okay with you using an alternative plan. I kind of put that as a very basic template for people who have not done them at all. But you're welcome to use your own template, and you can kind of just try to cite it the way that you, the best you can.
Well, I mean, I didn't cite it because we were just trained in it at work a few years ago, so I didn't really have a site for it.
You might want to put whatever your site is, treatment plan.
Okay. All right.
Any other questions about the format of the class or?
Dr. King, I have a question. I sent you an email also about the assignment 2, and I just hadn't heard back. Do you want me to resend that to you?
Yes, please, because I remember reading it, but I guess I didn't respond, so I'm sorry.
That's okay. That's okay.
It's been a little wild here at the beginning, so.
Yes, I agree.
I do remember reading it, but I honestly don't remember what it's about. So just, send it to me, and I'll get back to you ASAP.
Okay, I appreciate it.
All right, thanks. Any other questions? Okay, I did add some videos today. I think because in the last time I did this class, I did some lectures in the actual classes. So I just uploaded the bipolar disorders video today, as well as the mental status video. So if you want to look at those lecture videos, they're there for you. All right, well, that's all I have for you, and I hope you have a great evening. Thank you all for coming, and I'll see you next month.
Have a good night.
Thanks.
Right.
Bye.
Bye.